Usually, when you think about fixing a failing machine, the logic is pretty straightforward, right? Like if a pump is losing power, you give it more juice, you crank up the voltage, you clear the pipes. I mean, you do whatever you can to force it to pump harder.
Right, it's intuitive. You support the weakness by adding strength.
Exactly.
Yeah.
But stepping into the world of pharmacology today, specifically cardiology, well, that common sense gets thrown completely out the window.
Oh, completely.
Yeah, in the stack of pharmacology and nursing notes we're looking at for today's deep dive, we have this wild medical landscape. For decades, cardiologists were like absolutely terrified to give a certain class of drugs to patients with failing hearts, only to eventually discover that those exact drugs were the key to saving their lives.
It is arguably one of the most counterintuitive conceptual shifts in modern medicine.
It really is. So we are decoding the olol drugs today, the beta blockers. Tens of millions of people take them. If you check your own medicine cabinet or, a family member's, there's a really good chance you'll see a medication ending in OLOL.
Yeah, they are everywhere.
But our mission today, it isn't just to list basic medication side effects. This whole thing involves a Nobel Prize-winning breakthrough, a massive medical paradox, and a research scandal that basically forced international guidelines to be rewritten.
Yeah, we've got a lot of ground to cover. I mean, to really understand how we got here, we're going to travel back to the 1950s, look at how these drugs were invented from first principles, and then break down how they actually calm the heart.
Right.
And then, yeah, we'll dive into why they were once considered deadly but are now life-saving for heart failure, and finally wrap up with those critical safety rules that anyone managing these medications really needs to know.
Awesome. So take us back to the 50s. What was the big problem doctors were dealing with?
Well, back then, the huge killer was angina. And angina is that severe, crushing chest pain that happens when the heart muscle is just starving for oxygen.
Right, like an oxygen supply issue.
Exactly. You have a patient with coronary artery disease. Their arteries are clogged or narrowed, and when they exercise or get stressed, their heart naturally demands more oxygen-rich blood. But the pipes, they just can't deliver it.
And the standard approach at the time was all about trying to force more blood in, right?
Right. They use things like nitroglycerin to dilate the coronary arteries, basically trying to increase the oxygen supply. The whole focus was entirely on supply.
Enter Sir James Black.
Yes, Sir James Black. He was a Scottish pharmacologist working for Imperial Chemical Industries over in England, and he looked at this angina problem from a totally different angle.
Which is what makes it so brilliant.
It really is. Instead of trying to force more blood into a diseased, rigid heart, he basically asked, well, could we just lower the heart's demand for oxygen in the first place?
Right. It's like if you can't get more food to the hungry worker, just make the worker do less heavy lifting.
That is exactly it. And to achieve that, he relied on receptor theory, which, was a genuinely novel scientific strategy at the time. He didn't want to just test random plant compounds through trial and error.
Like they did with a lot of older drugs.
Exactly. He wanted to deliberately design a microscopic key to block a specific lock in the body.
And those locks are part of the body's natural response to stress, right? The sympathetic nervous system.
Classic fight-or-flight response, yeah. When you perceive stress, your body dumps catecholamines into your system. So that's specifically epinephrine from your adrenal glands and norepinephrine from your nerve endings.
Basically adrenaline.
Right, adrenaline.
Yeah.
These chemicals travel through your bloodstream and look for docking stations, which we call adrenergic receptors.
Okay, and there are a few types of these receptors, but Black was specifically interested in the beta receptors on the heart. Because when epinephrine docks at a beta receptor on the heart, it acts like a whip.
A very harsh whip, yeah.
It tells the heart to beat faster and squeeze harder. So his team comes along in the early 1960s, and they invent propranolol, right?
Yeah, propranolol. It hit the market in 1964 as the first clinically useful beta blocker.
Let me try an analogy here just to visualize what propranolol is actually doing. Think of the human heart as a struggling car engine. It's got clogged fuel lines, so it can't get enough gas.
Okay, tracking.
Epinephrine is like a heavy foot slamming down on the gas pedal. The engine is revving, is trying to work harder, but it's starving for fuel, which causes that terrible angina pain. Propranolol doesn't turn off the engine, but it does put a physical block under the gas pedal.
Oh, that perfectly captures the mechanism. Yeah, the drug literally sits on those beta receptors and competitively blocks epinephrine from docking. So, the foot can press all at once, but the pedal won't go down.
The block is physically in the way.
Exactly. The drug itself doesn't activate the receptor at all. It just shields it. So the heart calms down, the demand for oxygen drops, and the angina pain goes away.
Now, looking at the pharmacology notes, they use three very specific technical terms for this slowing down effect. The three tropics. Let's decode those for everyone.
Sure, let's do it.
First is a negative chronotropic effect. Chrono means time, so I assume this just means a slower heart rate over time.
Spot on. Slower rate, yes. The second is a negative inotropic effect. This means a drop in the actual force of the heart muscle's contraction. It literally squeezes less forcefully.
Okay, so slower rate, weaker squeeze. What is the third one?
A negative dromotropic effect. This refers to the electrical conduction speed through the heart, specifically through the AV node.
The AZ node.
Yeah, it's essentially the electrical relay station between the top and bottom chambers of the heart. A beta blocker actually delays the electrical signal as it passes through that relay station.
Got it. So we have a slower rate, a weaker squeeze, and a slower electrical signal. And this rational, deliberate design to achieve those three specific things was so groundbreaking that James Black won the Nobel Prize in Medicine in 1988, right?
He did. It proved you could design drugs from first principles, targeting specific microscopic receptors. I mean, it changed pharmacology forever.
But applying that discovery to different types of heart disease is where things get, well, incredibly complicated in the sources.
Oh, immensely complicated. Because lowering the heart's force of contraction, that negative inotropic effect, it sounds great for angina where the heart just needs a rest.
Right. But what if the heart is actively failing as a pump? Like, if a patient has heart failure, their heart is already barely able to push blood around the body.
Exactly.
Giving them a drug that explicitly weakens their heart's contraction sounds like you would push them straight into cardiogenic shock, like you'd kill them.
And that was the medical dogma for decades. You never, ever give a beta blocker to a heart failure patient. It was considered an absolute contraindication.
So what changed?
Well, we had to look at what's happening chronically, over months and years, rather than just minute to minute. Which brings us to the 1990s, when three massive randomized trials, MERIT-HF, CIBUS-2, and Copernicus, completely flipped cardiology on its head.
This is the massive paradox from the notes.
Yes. Researchers took a huge conceptual leap and gave specific beta blockers, namely carvedilol, metoprolol succinate, and bisoprolol, to patients with chronic systolic heart failure.
And the results?
They were staggering. The drugs didn't just fail to kill the patients, they actually reduced mortality by about 1/3.
Wait, okay, how is that physiologically possible? How does a drug that weakens the pump actually save the failing pump?
It all comes down to the concept of toxicity. When your heart starts to fail, your body essentially panics. It senses that cardiac output is dropping, so it activates that sympathetic nervous system to compensate.
Right, it dumps the adrenaline.
Exactly. It floods your system with epinephrine and norepinephrine to whip the failing heart into working harder, and minute to minute, that sympathetic drive is what keeps you alive.
But chronically, it's literally whipping a tired horse until it drops.
That is the perfect way to phrase it. That constant, unrelenting exposure to high levels of catecholamines is highly toxic to heart muscle. It drives what we call cardiac remodeling.
Oh, like it changes shape?
Yeah, the heart gets enlarged and floppy, and the actual heart muscle cells, the myocytes, they start to die off from the constant stress.
Okay, so the beta blocker is acting as a shield then. It blocks those toxic receptors. Even though you are slightly weakening the pump's immediate strength, protecting the heart from that relentless neurohormonal whipping is far more important for survival over the long run.
It's a profound paradox. You give a negative inotrope to save the pump. But there's a massive caveat here, especially if you are managing these medications clinically. This only works for chronic, stable heart failure.
Ah, meaning if a patient is in acute decompensated heart failure, like their heart is actively crashing right now, fluid is backing up into their lungs, they're suffocating, stopping their sympathetic drive is still incredibly dangerous.
Very dangerous. In that acute crashing moment, they absolutely need that baseline adrenaline just to maintain cardiac output.
So what's the rule?
The mantra for beta blockers in heart failure is start low and go slow. You wait until the patient is stabilized, out of the danger zone, and then you introduce a tiny dose to start building that shield, titrating it up very carefully over weeks.
Right. Start low and go slow. That makes total sense. Now, knowing that beta blockers act as this shield raises an important question for you. If I have a prescription for a beta blocker, are they all basically the same? Like, can you just swap one olol drug for another?
The answer is a resounding no. And this is because of a concept called receptor selectivity. Earlier, we mentioned beta receptors on the heart, but there isn't just one type of beta receptor in the human body.
Okay, what else is there?
Broadly, we have beta 1 and beta 2 receptors. Beta 1 receptors are mostly concentrated in the heart and the kidneys.
Let's pause on the kidneys for a second. The notes mention beta-1 receptors in the kidneys trigger the release of renin, which ties into the RAA system. What is the RAAS system actually doing?
So RAAS stands for the renin-angiotensin-aldosterone system. Think of your kidneys as the body's pressure sensors. If they sense blood pressure is too low, they release an enzyme called renin.
And that sets off a chain reaction, right?
Exactly. It produces a hormone called angiotensin, which powerfully constricts your blood vessels, and aldosterone, which tells your body to hold on to salt and water. Both of these actions drive your blood pressure way up.
So blocking beta-1 receptors in the kidneys stops that renin release, which helps lower blood pressure. That makes total sense. But what about the beta-2 receptors?
Right, so beta 2 receptors are found predominantly in the lungs, the blood vessels, and skeletal muscles. And in the lungs, stimulating beta 2 receptors causes bronchodilation. It relaxes the smooth muscle and keeps your airways open.
Wait, if beta-2 receptors are responsible for keeping the lungs open, and you give a patient a drug that blocks beta receptors, wouldn't a beta blocker trigger an asthma attack? Or be incredibly dangerous for someone with COPD?
You've hit on a massive clinical debate right there. And the safety entirely depends on which beta blocker you use. We classify them into cardioselective and non-selective agents.
Okay, break that down for me.
A cardioselective beta blocker, like metoprolol or atenolol, preferentially targets just the beta-1 receptors in the heart.
So at normal doses, it leaves the beta-2 receptors in the lungs alone, making it generally much safer for a patient with reactive airway disease like asthma or COPD.
Correct. But a non-selective agent, like James Black's original propranolol, well, it doesn't discriminate. It blocks beta-1 in the heart and beta-2 in the lungs.
Oh, wow.
Yeah, so substituting propranolol for metoprolol in an asthmatic patient is a dangerous mistake.
It's not a like-for-like swap at all. And the sources also mentioned carvedilol and labetalol are even more complex because they block beta receptors and alpha-1 receptors simultaneously.
Right, they cast a very wide net. Alpha-1 receptors usually constrict blood vessels, so blocking them adds an extra blood pressure lowering power by vasodilating the pipes at the same time.
That is fascinating. And because of these different properties, these drugs have some pretty wild real-world uses outside of standard cardiology.
They really do. Some beta blockers, specifically lipid-soluble ones like propranolol, can easily cross the blood-brain barrier.
Yeah, and since it crosses into the central nervous system, propranolol is heavily used off-label for performance anxiety. Musicians, public speakers, surgeons, like if you're a concert violinist, you can't have a tremor and your heart can't be beating out of your chest. But you also can't take a heavy sedative because you need your brain razor sharp for a concerto.
Exactly. Propranolol stops the physical peripheral symptoms of anxiety, the racing heart, the shaking hands, because it physically blocks the epinephrine from acting on those muscles.
But your brain stays clear.
Right. It doesn't dull the brain's cognitive focus the way a traditional anti-anxiety medication would. Though I will say, because it crosses into the brain, it can sometimes cause vivid dreams or nightmares as a side effect.
That's a crazy side effect. We also see beta blockers used for migraine prevention, essential tremors, and even thyroid storm, when a hyperactive thyroid causes dangerous tachycardia. But this application blew my mind, eye drops.
Oh, yes, timolol.
Timolol eye drops used to treat glaucoma. How does that work?
So you put a drop in your eye to reduce fluid pressure, right? But even topical drops can be absorbed systemically through the tear ducts.
Right, really?
Yeah, someone putting in eye drops for glaucoma could end up with a dangerously slow heart rate bradycardia because that beta blocker got into their bloodstream. You can never think of a drug in total isolation.
That perfectly sets up the darker side of this history. With great power comes great responsibility, right?
Yeah.
While these drugs are versatile, getting the dose, the timing, or the combination wrong can be disastrous. We have to talk about the perioperative beta blocker scandal.
This is definitely one of the more sobering cautionary tales in modern medicine.
What happened?
For years, based largely on a series of studies known as the Decrease trials, led by a Dutch researcher named Don Poldermans, international guidelines strongly pushed for routine beta blockers to be given to patients right before they went into non-cardiac surgery.
I mean, the logic seems sound on paper. Surgery is a massive physical stress. Stress causes a huge catecholamine release, so giving a beta blocker should blunt that stress response and protect the heart while the patient is on the operating table.
The logic was there, but the problem was twofold. First, between 2011 and 2013, an institutional investigation uncovered massive scientific misconduct in Polderman's research.
Oh, no.
Yeah, patient data couldn't be verified, ethics protocols were completely bypassed, the trials had to be discredited, forcing a complete rewrite of international perioperative care guidelines.
So guidelines affecting millions of surgical patients were based on fabricated data.
Unfortunately, yes. But even before the misconduct was fully exposed, the clinical reality was already showing the danger. In 2008, a massive study called the Poutiers trial tested this exact idea properly.
Okay, what did they do?
They gave about 8,000 surgical patients either a high-dose beta blocker or a placebo right before surgery.
And let me guess. Because they blocked the body's natural stress response, the patients couldn't keep their blood pressure up during the trauma of surgery, and they crashed.
That is exactly what happened. The beta blocker group did have fewer heart attacks, but they had a significantly higher rate of strokes and a higher overall mortality rate.
Wow, just from blocking that stress response.
Yeah, because of severe drug-induced hypotension and bradycardia. When the body is under the extreme stress of surgery and bleeding, it desperately needs that sympathetic drive to keep blood pressure up and keep blood flowing to the brain.
Right, of course.
So by suddenly imposing a high-dose beta blockade, the blood pressure bottomed out, leading to poor perfusion to the brain and ultimately strokes.
It's a vivid demonstration that just because a mechanism makes theoretical sense, it doesn't guarantee a benefit if the dose and the timing rob the body of its necessary defenses. We saw a similar downgrade in the hypertension world, didn't we? Beta blockers used to be the automatic first-line treatment for basic high blood pressure.
They were, yeah, until trials like the LIFE trial showed that a drug like atenolol was actually worse at preventing strokes than other classes of drugs like ARBs.
ARBs are angiotensin receptor blockers, right?
Mhm.
They work on that RAS system we talked about earlier, blocking the angiotensin hormone so the blood vessels can dilate.
Yes. It turns out that for simple high blood pressure, treating the piping by vasodilating with an ARB is much more effective at preventing strokes than just weakening the heart pump with a beta blocker.
So guidelines downgraded beta blockers across the board for that.
Right. You generally only use them first line now if the patient has another compelling reason, like heart failure or previous heart attack.
Considering all these risks, let's map out the most crucial survival rules for anyone managing these medications daily. We've got a list here. Rule number 1. The pulse check.
Absolutely vital. Before administering a beta blocker, you must assess the patient's apical pulse. That means listening with a stethoscope directly over the heart, the apex, for a full 60 seconds.
And what's the cutoff?
Generally, you hold the medication if the heart rate is below 60 beats per minute or if the systolic blood pressure is below 90 to 100. You don't want to compound a bradycardic or hypotensive state.
Rule number 2. The hypoglycemia mask. This is a classic, totally counterintuitive scenario. If a diabetic patient's blood sugar drops dangerously low, their body's alarm system sounds right. It dumps adrenaline, which normally causes a racing heart and shakiness.
Right, but if they are on a beta blocker, those receptors are shielded. The tachycardia and tremor are completely masked. They won't feel those crucial warning signs.
However, the notes say one warning sign does get through. Diaphoresis, sweating.
Yes. Because sweating isn't driven by adrenergic receptors, it's a cholinergic response. It uses a totally different chemical pathway that beta blockers do not touch.
Oh, that is such a key distinction.
It is. So you have to teach patients, if you start sweating profusely for no reason, trust the sweat. Check your blood sugar immediately.
Rule number 3. Dangerous combos. The sources explicitly warn never to mix beta blockers with a specific class of calcium channel blockers called non-dihydropyridines. Drugs like verapamil or diltiazem.
Right, because both beta blockers and these specific calcium channel blockers slow down the heart rate and delay electrical conduction at the AV node.
The relay station.
Exactly. If you combine them, you are hitting the heart's electrical relay station with two massive blockers at the same time. You risk severe, potentially fatal additive bradycardia or complete heart block, where the electrical signal just completely stops.
Which brings us to the final rule. The withdrawal danger. Never stop taking a beta blocker abruptly. I imagine this has to do with how the body adapts to the drug over time.
It does. It's a fascinating physiological response called supersensitivity, which is driven by receptor upregulation. When you block beta receptors day after day, the body realizes it's not getting the sympathetic signals it expects.
So it fights back.
Exactly. To compensate, the body physically builds more beta receptors and makes them more sensitive.
The body is actively building a new alarm system to fight back against the drug. So if you quit the beta blocker cold turkey, suddenly the shield is gone.
Mm.
But you don't just have your normal amount of receptors exposed. You have millions of extra highly sensitive receptors completely exposed to your circulating adrenaline.
And your baseline adrenaline hits all those extra receptors at once. It triggers massive rebound tachycardia, severe hypertension, and if the patient has coronary disease, it can instantly provoke a heart attack.
So what do you do instead?
You always have to taper these drugs over a week or two to let the body downregulate those receptors naturally.
Let's synthesize this incredible journey. We started with James Black, looking at a struggling heart and deciding to put a block under the gas pedal rather than trying to force more fuel into the engine.
Such a brilliant shift in thinking.
Really was. We uncovered a massive paradox where weakening the pump actually saves it from toxic adrenaline in chronic heart failure. And we mapped out the vital safety rules, from the dangers of eye drops to trusting the sweat during low blood sugar.
It's a remarkable drug class that really illustrates the profound complexities of human physiology.
If you ever look at a family member's medication bottle and see an olol drug, you now understand the invisible mechanics happening beneath the surface of that tiny pill.
And, thinking back to that withdrawal danger, the idea of receptor upregulation, it poses a fascinating philosophical question for you to mull over.
So lay it on us.
We invent these brilliant Nobel Prize-winning medications to force the body to behave a certain way, but the body's microscopic drive for homeostasis is so relentless that it will literally grow new biological hardware, new receptors, just to fight back against the drug and return to its baseline.
It really makes you look at the human machine differently. The next time you take a daily medication, consider that invisible adaptive battle happening inside your own cells. The mechanics aren't just static metal and pipes, they're alive, and they push back.